Hello, everybody. My name is Stefan Anker, and with me is Shelley Zirov, and we together have the great pleasure of sharing now this session about intravenous iron therapy for heart failure patients, reviewing new evidence. And out there, you're already 500 spectators, so stay tuned for 3 exciting presentations by Piotr Ponikovsky, Javed Butler, and Andrew Coates. And then we shall have some question and answers, and you can post them as you know. Looking forward to this. Over to Piotr now.
Thank you very much for the invitation for this meeting. Today I'm going to present you the new evidence from our AHF study, and particularly translating this for the clinical practice. Here are my disclosures. I can very well remember last year, virtually exactly 1 year ago, we presented our AHF study at the American Heart Association. And from this study, we concluded that in patients stabilized after an episode of acute heart failure with concomitant iron deficiency, treatment with ferric carboxymaltose reduced the risk of heart failure hospitalizations, and the treatment was safe and well tolerated. I think it has a real implication for everyday practice. At that stage, we defined iron deficiency in heart failure in this context as being a target for intervention, should be always assessed in all patients hospitalized with acute heart failure, and because it can be easily detected using a simple blood test, it should comprise our everyday routine practice. Today, I'm going to give you some more data and a little broaden these clinical implications. First, the new evidence in the context of the effect of quality of life. In this study, we use KCCQ-12 questionnaire to assess quality of life. This is depicted on this slide, and as you can see, we use this scale to assess different elements of quality of life. The scale are scored from 0 to 100, with the lower the poorer. And here is the summary. As you can clearly see, AHF tended to comprise patients with very poor quality of life at baseline. Only Soloist's trial had the same kind of a patient population. Other trials with more stable patients comprise those with much better, although poor, but better quality of life. So the fundamental question is, are we going to improve quality of life with ferric carboxymaltose? And the answer is yes. These are the data using a questionnaire focusing on assessment of symptoms, functional limitation, and quality of life. As you see here, the effect is very clearly seen and starts already early after 4 weeks. Here is the assessment of symptoms and functional limitation. Again, clear effect in those improvement in those treated with ferric carboxymaltose seen already early after 4 weeks of therapy. Please remember, these patients tended to be very poorly affected from the very beginning. What about cost effectiveness? So I said we want our patients to live longer, to live better, but cost effectiveness matters a lot. So we performed the analysis in UK, US, Switzerland, and Italy, kind of as surroundings. And then we demonstrated that ferric carboxymaltose was associated with really discounted quality gains versus placebo in UK, in Italy, Switzerland, and USA. Here you see the data, and ferric carboxymaltose treatment was either dominant or highly cost effective. And here is a summary of the results. And I think that the last point is of real importance. And I can only say in one sentence, ferric carboxymaltose is not only well tolerated, it's not only effective, but also it reduces the burden on the healthcare systems across all countries we studied. Another interesting data, very briefly, the effects according to baseline eGFR. As you see here, we divided our patients in tertiles. 1/3 tended to have a eGFR below 40, 1/3 between 40 to 60, and 1/3 over 60. You can clearly see the effects are seen and evident across the whole spectrum of eGFR in the context of the primary outcomes, so hospital admissions, improvement, but also in the context of quality of life. The obvious question is whether the therapy works in patients with anemic and non-anemic patients. We made a first attempt in our primary paper, published 1 year ago in the Lancet. However, here we have much more detailed analysis showing the primary and secondary outcomes with ferric carboxymaltose versus placebo by anemia status. As you can clearly see, all primary outcomes and secondary outcomes are equally improved, favorably improved, regardless patients had baseline hemoglobin level below or above 12 grams per deciliter, and here is the same in the context of quality of life. So, as a conclusion, ladies and gentlemen, Mr. Chairman, I would like to say that today I'm going to broaden the conclusions we presented 1 year ago. So we presented that 1 year ago that we are able to improve the outcomes with ferric carboxymaltose. The treatment is safe and well tolerated. And today I would like to say, based on the new evidence, treating iron deficiency with IV ferric carboxyl in this high-risk population, we are able also to improve quality of life. The treatment is cost-effective, and the effects are seen across the whole spectrum of baseline eGFR, irrespective of baseline anemia status. Thank you very much for your attention.
Greetings. I'm Dr. Javed Butler, Professor and Chairman, Department of Medicine at University of Mississippi in Jackson, Mississippi. Delighted to give this short presentation, New Evidence from Meta-Analysis, Lessons to Learn on the Benefits of Intravenous Ferric Carboxymaltose in Patients with Heart Failure. These are my disclosures. So recently there were 2 meta-analyses published looking at the effect of iron replacement in patients with heart failure who were iron deficient, regardless whether they had anemia or they did not have anemia. One of the meta-analysis looked at all the trials and all the data, randomized data that we have with patients who received ferric carboxymaltose, and the other one looked at all IV iron preparations data together. So let's look at these 2 studies. So let's start first with a study that is specifically focused on ferric carboxymaltose. This meta-analysis took all the studies in order to avoid sort of single center, small experiences. They looked at larger studies, at least 100 patients, at least a follow-up of 24 weeks, and patients were randomized to ferric carboxymaltose or placebo. So that was a requirement to get into the study. About 5 studies were included, close to about 2,000 patients, 1947 patients were included. Now, in this study, there were some data that were included from published studies, and then there was some data that was included from studies that were published in a previous meta-analysis that was updated, but the individual studies were not published by themselves. These are all the studies that were part of that meta-analysis, and as you can see, the hemoglobin range less than 15, 9.5 to 13.5, so that's sort of the range of hemoglobin that was included in this study. So what did this meta-analysis show? This meta-analysis basically, again, confirmed that the replacement of ferric carboxymaltose in patients with heart failure, reduced ejection fraction, who were iron deficient, led to a reduction, substantial reduction in the composite of cardiovascular death or heart failure hospitalization. This is based on published results of AFFIRM-HF, FAIR-HF, and CONFIRM-HF. CONFIRM-HF, FAIR-HF were outpatient trials. AFFIRM-HF was an acute heart failure study. So this result excluded patients from the studies that were not peer-reviewed, published by themselves. This result was mainly carried by the heart failure hospitalization results per se. You can see there was a remarkable 39% relative risk reduction that was seen for heart failure hospitalization. There was no risk in cardiovascular mortality or all-cause mortality reduction that was seen. There was no risk either, but that was not seen by itself. Now, if you include the 2 studies that by themselves are not published and kind of take the old meta-analysis and then add the new study, the AFFIRM-HF, to it, basically basically, there was no material change in the results. We still saw a reduction in the composite of cardiovascular death and recurrent heart failure hospitalization. We also assessed not only time to first hospitalization, but recurrent heart failure hospitalization. Also, there was a 32% relative risk reduction that was seen. And again, mortality by itself was not positive, as is seen here. So significant reduction in time to first heart failure hospitalization, cardiovascular death, 24% relative risk reduction, but cardiovascular death by itself did not go down. So the second meta-analysis looked at all iron studies. So again, a meta-analysis of a few more patients were added, about 2,166 patients. So these were all the studies. This included 2 studies with iron sucrose as well. And again, materially no differences in the results. We saw consistent benefit that IV iron replacement in iron deficient heart failure patients, 23% relative risk reduction in heart failure hospitalization, cardiovascular mortality risk, substantial reductions in heart failure hospitalization, as one can see here, 33% relative risk reduction. Cardiovascular death went in the right direction, 11% relative risk reduction, nowhere close to being statistically significant, and we obviously need larger powered study to specifically answer this question by itself. Now, this includes the results that I just showed you included studies both in the outpatient setting and the inpatient setting. The largest of this study was the AFFIRM-AHF. So it was different in 2 ways. 1, it was the largest study. 2, it was the acute heart failure study. So the question is it overshadowing the results? So if you take out the AFFIRM-AHF and just leave all the other iron studies that were done in the outpatient setting, again, no material difference. If you look at the results after excluding AFFIRM-AHF, the composite endpoint of cardiovascular death, heart failure hospitalization, 41% relative risk reduction, substantial reduction of 43% relative risk reduction in hospitalizations for heart failure. And here, again, small numbers, so you have to be careful, but there was a substantial reduction in cardiovascular mortality, did not reach statistical significance, but at least these data are making it interesting that perhaps we should do studies to look at cardiovascular mortality long-term outcomes trials as well. So what is in store going forward? Well, there is a lot of interest that iron deficiency is very common in patients with heart failure and preserved ejection fraction. Also, all the data that I've shown thus far are in heart failure with reduced ejection fraction. So there are 2 smaller sort of studies going on in heart failure with preserved ejection fraction to start getting some idea about what happens with iron replacement in these patients with heart failure with preserved ejection fraction. But more importantly, because now we have a large in-hospital trial powered for hospitalizations showing substantial benefit, and all of these directional but statistically non-significant trends for mortality, we really need large mortality morbidity outcomes trial and not only functional capacity, quality of life based trials. So there are 3 trials going on. FAIR-HF2 and HEART-FIT trial. These are with ferric carboxymaltose, and then Ironman with another iron preparation as well are ongoing. These are larger trials that are powered for mortality and morbidity, and we will get those results soon. So to summarize, we know for a long time that iron deficiency is common in patients with heart failure. Reduced ejection fraction is associated with functional capacity disturbances, quality of life, poor scores, mortality, morbidity. We know for a long time that replacement of iron in these patients, regardless of anemia, is associated with improvement in symptoms, quality of life, and functional capacity. And now with these meta-analyses, we know that there was a substantial improvement in the risk for combined cardiovascular death, heart failure hospitalization, time to first heart failure hospitalization, recurrent heart failure hospitalizations as well, and future trials with longer term, bigger trials will give us further data on mortality, morbidity in the outpatient setting. Appreciate the opportunity to briefly talk about these 2 meta-analyses with you.
Now over to Andrew.
Hello, I'm Andrew Coates, President of the Heart Failure Association of the ESC from Warwick University in the UK. And I'll talk about what the guidelines say about iron deficiency. Of course, we've had the recent European guidelines presented just at this meeting. So the European guidelines back in 2016 did have mention of intravenous iron and iron status in a couple of places, but you really had to look for them. So under recommendations for screening, there was buried in there amongst a number of tests, and I think possibly not really picked up by many people. But there was a section in the comorbidities, specifically on iron deficiency anemia, that gave a class 2A recommendation in tabular form for the use of intravenous ferric carboxymaltose, a should be considered level of recommendation in symptomatic pain to alleviate symptoms and improve quality of life and exercise capacity. So I think this was a major step forward. But then when we turn to 2021, it's in a number of places. In the front of the paper is what is new, and number 9 of those include the recommendations for the management of patients with heart failure and iron deficiency, pulled out as a specific kind of comorbidity. And we see there are 3 recommendations. Importantly, there's a class 1 recommendation for patients with heart failure being periodically screened for anemia and iron deficiency. That's very important because it's not just a one-off, but you need to do that regularly. Furthermore, as confirmation of intravenous iron supplementation with ferric carboxymaltose should be considered for symptomatic patients. Now to reduce the risk of hospitalization on the basis of the AFFIRM-AHF study. And of course, there's a related recommendation not to use erythropoietin stimulating agents. Now, very importantly, under the recommended diagnostic tests in all patients, recommendation. And although the therapeutic algorithm, central one, doesn't include iron deficiency or iron replenishment, the much more viewed algorithm, which is the one that everyone's focusing on, which is a central management options below the famous 4 foundational therapies, is a specific call out for iron deficiency in the patient profiling, recommending ferric carboxymaltose. The yellow color recommends the fact it's not a class 1, but a class 2 recommendation. And furthermore, there's very specific recognition in the pre-discharge checklist that ferric carboxymaltose should be considered for iron deficiency in this pre-discharge setting after admission for acute heart failure in patients with a classic definition of iron deficiency to improve symptoms and reduce rehospitalization rate, recommendation 2AB, as well as a recommendation for the management of anemia and iron deficiency, which is a bit more robust than it was in 2016, with the periodic screening, the supplementation to alleviate symptoms, improve exercise capacity and quality of life in chronic heart failure with ejection fraction 45%, along with that recommendation for acute heart failure management, where the ejection fraction range is put up to 50%. And lastly, even in the diagnostic assessment, patients with suspected cardiomyopathy includes iron status. It's not clear whether that's for iron overload, but if it picks up more iron deficiency, I think that will be a good thing given we have a treatment for it. So in summary, iron deficiency is now a very well recognized part of the ESC heart failure guidelines. It's class 1A for periodic assessment of iron status, which is the essential first step to get this treatment for our patients to benefit them. It's recommended as a pre-discharge assessment tick box, and it's a class 2A recommendation for therapy of chronic HFrEF, as well as a class 2A recommendation in recently acute decompensated HFrEF to reduce the rate of heart failure hospitalization. So I think it's fair to say it's now made the main line of treatments for heart failure. Thanks very much. Look forward to the discussion.
Thank you so much. This was really enlightening to all of us. Maybe we can put also Javid and Piotr in the screen for the panel. Shelley, maybe over to you for the first questions.
Certainly. So, it was really great to see the quality of life improvement data that was presented, as well as the cost effectiveness from Professor Ponikowski. So there's a question here. Was there a need to repeat ferric carboxymaltose treatment during follow-up? If so, was there further improvement? Great question.
Do you want me to address this question?
Sure.
Well, yes. Originally, to be honest with you, we wanted the design of the study to be as simple and as practical as possible. This is why we decided to sort of focus on the first 6 months period. Although your point is very well, or the person who asked the question point is very well taken, if only we could continue with this, because at the end of the day, we can now say that not everybody was repeated. So yes, perhaps longer treatment, that's what Stefan does in his FAIR-HF2 trial. However, with stable patients, to continuation of the therapy may well be a better idea, if only we could plan this way. That would be my humble comment.
Yes, we have so many viewers, 700 now, that I would like to ask the panelists to be short and snappy to the point so we can address many questions. Maybe, Piotr, again, how do we assess iron deficiency in acute situations where we know that ferritin is also acute phase reactant and goes up?
Well, I remain a little bit dogmatic and say, why not to take something which works? So TSAT and low ferritin, I think, combined or assessed in separation, as suggested by the current guidelines, is a very good idea. I would opt for this. My gut feeling tells me that some future biomarkers will be available, but whatsoever, these two would be my strong and humble recommendation. If I am sharp and to the point, I don't know, you judge.
But by adding this last sentence, you're not sharp and to the point. Anyway, Andrew, how often is periodically by the guidelines? You are representing the guidelines here. Enlighten the audience.
Well, it's not specified, but I think it's fair to say whenever a patient deteriorates, and at least once a year would be my thing, iron status is a very inexpensive blood test and it could make a huge difference. So I think we should do it regularly.
Shelley, any more questions?
So I have a question for Javed. You highlighted the differences between inpatient and outpatient treatment of iron deficiency. Can you just clarify for the audience if there are in fact differences, and any I guess helpful tips as to implementing initiation of outpatient treatment for iron deficiency that you might have?
So there are no differences in outcomes in the inpatient or the outpatient. It's the level of evidence. So in the outpatient setting, those primary endpoints were on functional capacity, quality of life, symptoms, they were improved. Meta-analysis clearly shows improvement in hospitalizations. The inpatient trial was powered for clinical outcomes and also showed the same quality of life and hospitalization benefits. So it's pretty consistent. Now the question is, will all of this translate into a cardiovascular mortality benefit? And those power trials are ongoing, and we will hear more hopefully in the future. But very consistent results, regardless whether the study was done in inpatient or outpatient setting.
So here's a question for those of you who basically have the broadest experience. Now, when you have limited resources, and on the one hand may not have available ferric carboxymaltose, or on the other hand may not have available any IV iron. So what about oral iron? What about other IV irons to replace ferric carboxymaltose?
Whom you wish to answer?
All of you, as I said.
15 seconds of the time. I would not recommend oral iron whatsoever. We do not have strong evidence for this. I would stick to ferric carboxymaltose if I were rich. If not, most likely I would go for another product which is now in the testing phase, but only if I were poor or poorer, according to your kind of a description. That would be my humble advice.
And Andrew, what do the guidelines say about oral iron?
Well, there's no recommendation for it. So I think there's no point doing something inexpensive if it doesn't work. A cheap product that doesn't work is an expensive product.
But let's first of all, let's take out the word expensive and cheap here. We are talking maybe an annual treatment expense between 500 and 700, possibly €1,000. That is below many of the other cardiovascular drugs we are using. That is similar to, for instance, empagliflozin, €500 per year. So at least in Europe, maybe not in America. So basically, cost is very relative. You spend it every 4 or 6 months. but then in between, you actually have covered already the treatment. So I wouldn't call this expensive. The other point is, Piotr, in your initial experience, we also used iron sucrose in the phase 2 studies.
Stefan, one quick comment. Most vast majority, 80% of our patients needed only 2 injections. So I would not call it expensive. This is pretty reasonable pricing. And even if we continue, I would say 2 to 3 injections per year to avoid 30 to 40% of hospital admissions is really something that would be, and improve quality of life. That's unquestionable. That would be my comment at that moment.
Andrew?
Can I just reinforce what Piotr said? The cost efficacy paper Piotr referred to actually was in 4 countries. In Italy, it was a minimal cost for each quality adjusted last year. In the other 3 countries, US, UK and Switzerland, it actually saved money. It wasn't a cost to the healthcare system. It actually saved money by reducing the hospitalization costs.
Excellent. Javed, what do you think? Other IV irons? Any evidence for them at all in heart failure?
Well, I mean, we have seen that whenever we go for class effect, we find unpleasant surprises. And we have many examples with DPP-4 inhibitors and beta blockers that the best advice I can give is to stick with where the evidence is.
Yeah. Shelley, what else is asked online? I saw one question that was basically addressing the question of, after you're treated, when is the first time you should reassess the patient? People ask very practical questions.
Well, Stefan, I can hardly hear you. Could you kindly repeat the question? Sorry, somehow lost your voice.
When you are treating a patient and correcting iron deficiency, when is the first time to reassess the patient?
I would say couple of weeks minimum. Don't reassess after 2-3 weeks because you may have abnormally high biomarkers. Please do this after 6 weeks, maybe 2 months. That would be a reasonable. That would be my suggestion. You have one shot, couple of weeks, and then reassess if you are still uncertain. We did this even in more simplified protocol. In the current study, we are just about to start and do this regularly after 4 months.
And I think we have 1 more minute. There's a lot of questions here about the use of ferric carboxymaltose in HFpEF, and I think it was, I can't remember if it was Andrew or Javed who actually highlighted that in their presentation.
So Stefan, maybe you should take this question.
Well, basically, we are now trying to extend the FAHF2 trial results, looking at what is presented also here at the Congress to patients with ejection fraction below 60%. So then basically in the near future, we should be able to report about HFrEF, HFmrEF, and even HFpEF up to, let's say, 59% from the FAHF2 trial. The amendment is written as we speak. Any other famous last words? Piotr, Andrew, you want to give on this subject? Well,
we have a responsibility. If we have an effective treatment, if you look at the guidelines, very few of the treatments are actually directed at exercise tolerance and quality of life. And I think we really need things. And this is a treatment that patients actually feel better. So I think it's very important that we take it seriously.
Fully agree. 30 seconds. Just remember to screen for iron deficiency. And although intuitively we link this with low hemoglobin, it is not always like this. So please remember that this is far beyond this anemia story.
Shelley, for you to close.
This is an important part of managing our heart failure patients. We need to screen for iron deficiency. If you're not doing it, start doing it. There's effective treatments that improve quality of life and reduce heart failure hospitalizations, and do so in a cost-effective manner as well. Thank you so much for our panel today and our excellent faculty for their presentations. Stefan, it's been a pleasure co-chairing with you. And I hope everybody enjoys the rest of the ESC Congress.
Thank you so much and see you soon.